Hi, thank you for having me. I'm really pleased to be here. I think I was selected based on 3 criteria. One, I'm a physician. 2, I was critically ill. And the 3rd, most importantly, I survived it. So who am I? And I think all of us wear multiple hats. I'm a husband, a father, I have friends, believe it or not, despite a career, a kidney transplant surgeon, and an avid Giant fan. It's hard to be a Giants fan. Well, what happened? Well, almost 9 years ago, on December 10th, 2005, I thrombosed my left main. And clearly in the morning, I knew I was having a heart attack. I called my neighbor first, believe it or not, because we were going to go down to Atlantic City to play a little poker. And then I called my wife. I got up to open the door for 911 as I was calling 911 and never made it past the bedroom. Luckily, my neighbor had the wherewithal to make sure 911 was there. He opened the house for them, and next thing I knew, I was woken up February 16th. So in the intensive care unit for quite a few weeks, and I think that's what was interesting about my stay, my experience as a patient through this period. Well, what really happened? What was the details? Clearly, I had a major MI. I was intubated, had major problems. The first, which contributed to ongoing issues, is immediately I had HIT, which no one was aware of. My platelet counts dropped to about 7,000, continued to throw off clots, and it was a problem throughout. In the Somerset, where they took me first, a local hospital, they maxed me out in presses, they put a balloon in, and they shipped me off to Rutgers, where a heartmate was waiting for me. So obviously, when they sent me over there, I had a blood pressure in the 50s. Not surprisingly, it resulted in multiple system failure. I had a shocked liver, renal failure, respiratory failure, and further on in the course, I developed a resistant Klebsiella infection that had no particular antibiotic was cidal against it. Fortunately, the infection occurred after December 20th. I was lucky enough to get a heart transplant on December 20th. The transplant was from a woman who was 50 years old down in Delaware. Well, as you can imagine, when I woke up, I was extremely weak. I was hypermetabolic through that period of time. In that 6-week period, I lost about 70 pounds. I came in around 205, and at that time, I was weighing 135 pounds. What was really scary about the first day that I woke up, because I had been so weak, I could not move 3 of my 4 extremities. I had some motion in my left hand, and I think that was scarier than the fact that I had a heart transplant. People did ask me when I woke up, are you comfortable with the fact that we gave you a heart transplant? And the obvious answer was, of course. There was really, I wouldn't have been there without the heart transplant. Anyways, I went on to the rehab, and I found the rehab facility to be somewhat limiting in that they work with you as hard as they can, but they're limited by the hours, the staff. As soon as I could get myself off the floor, I went home, where I would cycle my rehab as far as getting up, eating, working out, taking a nap, and doing the same thing over 4 or 5 times a day. And that way I was back at work 6 months after the event. And if I had to do anything over again, I probably would not have gone back so quickly. People at work were a little aghast at how I looked. And it took a while for people to get adjusted to somebody who looked so robust to come back fairly frail. Well, here I am getting ready to leave. I don't know if you can tell from the picture, but I'm fairly slight. This is my wrestling weight in high school, which I never thought I'd see again, and this was not the way I expected to get back to that weight. Well, who belongs in that critical care unit? And I think I did qualify. There was some criteria that have been written about. Any patient that's at risk for decompensation, any patient who is physiologically unstable, and any patient who requires minute-to-minute titration to make sure they're hemodynamically stable. And I fit all 3 criteria. Well, what's the physician's role, the physician component? And we'll talk about this a little bit more, and depends on the model, but the most important role of the physician as the intensivist is to coordinate the leadership of a multidisciplinary approach. They have to be immediately available and no higher priority. That should be their goal, is taking care of the patients in the unit, more important than an educational event, a learning event, or surgery. So our unit over the last 9 years that I've been at Rutgers Medical School has been a unit in transition from an open unit where the primary physician who took care of you and operated on you followed you throughout the stay to one that's semi-closed and will take some input from the referring doctors. So I have some experience looking at it over this period of time, and we'll summarize at the end my feelings on all that. So currently, at that time when I had the event, the patient care was directed by a single physician, the operating surgeon, and the orders were carried out in conjunction with the experienced nurse practitioners and the fellows. There was multiple consultants involved, an extremely experienced nursing staff, the respiratory therapist, the physician therapists, and technicians. And obviously, you can see when someone's critically ill, it does take a village. And I think I learned to appreciate a patient all those individual components that make up the critical care team. Well, the operating surgeon, well, I think there was some good and bad with having a single surgeon responsible for everything. In this particular case, the surgeon who I'm grateful for took personal responsibility for every moment I was in that unit. On December 26th, I became septic enough where they called the family in, and there was a question whether they're going to survive the night. And that physician stayed there by my bedside, in and out, making sure whatever could be done was done. And lo and behold, I managed to get through that night, and that was a turning point. So, lucky enough, and depending on the individual taking that role, I happen to have an experienced surgeon who was experienced not only as a technician, but with medical expertise. There was a consistent plan of action that was run by one person and didn't change from week to week. There was no catch-up. There was no transitions between teams. And there was a single physician to the family to talk to. The operating surgeon, though, there was some difficulties, as you can imagine, having a single physician. He made morning rounds at 6:30. He had many obligations, including operating. Cardiac surgeons start very early in the day, often unavailable through the day, and also there's clinical responsibilities. I think if it wasn't for the overall medical community and being involved in the medical community, my family might have felt a little bit left out because there was sometimes limited time to discuss critical issues with a single busy surgeon. And the other issue that happens that I think may be difficult with a single provider is that during the day, if something arose that was problematic, the doctor may not be in the operating room, and certainly nobody wanted to interrupt the surgeon during an anastomosis, and those decisions would have to be put off till he was available. And then I think the good and the bad was that there was all the final decisions went through him. And so he was able to coordinate everything. But again, it would wait for his availability. So I don't think that was such overwhelmingly a negative, but clearly there were some issues with having a single provider. Well, as you can imagine, somebody who was as sick as I was, there was multiple consultants from the hematologist for HIT, the infectious disease. Not only did I have the Klebsiella, as you can imagine, and surprising to me, since I grew up in New York and New York City, I was CMV negative. The donor was CMV positive, and of course, I had CMV, primary CMV. I had C. diff along the way, and so clearly there was multiple infectious problems. The most difficult with that Klebsiella I mentioned. I had acute renal failure, vascular surgery was involved, pulmonary, cardiology, GI, psychiatry. Just as a side note, I thought it was pretty funny in that one of the bills I did get was from the psychiatrist. To be cleared for a heart transplant, you have to be interviewed by the psychiatrist. And I just was wondering how this particular doctor interviewed me when I was unconscious. It must have been a little one-sided. But there was a bill for it. It was a multiple specialty approach. And then, as I'm sure everybody here in the audience knows, that you also often get conflicting recommendations. I can imagine the heart team wanting me dry and the the renal team wanting me wet and the infectious team wanting some nephrotoxic agents. And so there's always a conflict there between the specialties, and it does require one individual to put it all together and make the final decisions. And so it's incumbent on that one doctor or the critical care specialist to be there to integrate all those different recommendations. I always appreciated nursing care. And in fact, when I round in Transplant, that we're mandated by CMS some multidisciplinary rounds, that we have the hepatologist or the nephrologist there, along with the surgeon, the coordinator, and the nurse taking care of that patient, whether it's in the unit or on the floor. But I don't think I really ever appreciated how much a nurse does until I was a patient. There's such an intense relationship that's built between the patient and the nurse during that period of time. And I've always had respect for nursing, especially since my wife's a nurse anesthetist and my middle daughter is a critical care nurse. I couldn't help but have respect for that, but even more so being a patient. Clearly, a critical care nurse has to be independent, motivated, organized, be able to prioritize what the problem is, what takes precedent, which presses from moment to moment. Really, it's a unending moment-to-moment job. On top of that, they have to be compassionate and patient. And I have to say, I suspect when I woke up, I wasn't the easiest patient to take care of. So, as you can imagine, I ended up loving my nurses. There's that intense contact. As I said, not only do I have to recognize and report to the doctors, sometimes they have to make these moment-to-moment decisions. They have to effectively implement the physician's orders and timely recognition of changes in clinical status. On top of that, they're the ones that are really communicating, the daily events and interact with the family more than the physicians on a routine basis. Well, here's the current nursing staff. I do want to highlight this one woman here, Claire, who just amazes me. When I was sick and finally being able to get out of bed, I was too weak to stand, and somehow this woman managed to pick me up and put me in a chair. It's remarkable what this team can do, and I'm sure everybody has a similar team at home. Well, the team included a respiratory therapist who, again, kept me informed. I always wanted to know what my blood gases looked like, how I was doing. I had some pulmonary problems from the CMV. The respiratory therapist, the physical therapist. As I mentioned before, the scariest part was that I woke up with not a lot of function. And as soon as I woke up, my goal was, am I going to be able to operate again? The physical therapist and occupational therapist brought some operating instruments into my room so I could begin again. They instructed my family with range of motions, and we got the ball rolling as early as possible. Well, the family. From my family, and I spent some time recently talking to my wife, reviewing this, and certainly they had some difficulties in talking to the surgeon from the operating room, although they felt it was okay. We were in the medical family, and so all those deficits were picked up by everybody else. The question about emotional support and clergy is kind of interesting. I think the clergy was there perfunctorily. I had an interesting conversation. I'm Jewish, and the rabbi came by, who's Orthodox, didn't really believe in donation, and I just thought it was an interesting conversation because I was sitting there alive because of organ donation. There was financial concerns that, of course, in the medical community is never talked about. And you're laying there wondering how long you're going to be sick, where the income for your family is going to come. Is the medical school paying me for laying here, and how much and how long? And so none of that gets discussed at all, despite trying to bring up those issues. Transition to rehab at home, as I mentioned, I probably wasn't a great patient at rehab. For the time they had me, I worked very hard at it. I just felt it was inadequate for the amount of intensity that I wanted to bring to my rehab. The rehab is very cookie-cutted, organized to deal with everybody. I just wanted to do that much more. And then coming to grips with your image change, not only how you view yourself, but how the world views you. None of these issues are really discussed along the way. So this is a video put together by the hospital. So it's a little bit about the hospital, but I wanted to bring this video to the group to see what it took to make this happen. Oh, let me go back. Here we go.
What do I want for my birthday?
This is my daughter speaking.
As if something material is worth anything right now. I want you to walk. I want you to get out of this hospital. Not to be hooked up to any machines. To be at home. To not be sick. To rewind time so we are before the hospital, before the heart attack. What can you give me that is equivalent to your life? For my birthday, let's switch places. Protect me again.
It was a Saturday morning in December 10th, when I got a phone call from his wife, Mary. She said that David Laskow had had a heart attack.
Bright and early in the morning, I started having some chest pain. I'm thinking to myself, it was a little atypical that if I started sweating, this was cardiac. And within a few seconds after that, it was clear that I was having a major heart attack.
When I first got the call saying that David was in trouble, and I had to ask them several times if it was actually David.
Dr. Laskow had been very healthy, very active.
And vibrant leader in the medical community.
I was actually visiting a college. I was visiting Bard, and my mom called me, and she was like, well, make sure you get back on this train. And I was like, why? And she was like, well, you know, your dad had a heart attack. Like, you have to get on this train and come back. And there was just like, I don't know, it was really weird because I it's like almost didn't believe it at first.
I was surprised to see how sick he actually was. There are, of course, heart attacks, and his was one of the worst situations that I had ever experienced.
It was imperative for us to transfer him here to Robert Wood because we do have basically anything that he could have possibly needed.
We sent an ambulance there to be ready. At that time, the doctors and the family decided he was too sick, and so the ambulance was sent away. We parked it around the corner, and we kept it there for hours until the time was right.
He was rushed to the operating room where a left ventricular assist device was inserted.
It was decided that he would require a transplant.
There was a period of time when his kidneys shut down, and this is not at all unusual, even with healthy kidneys, when someone becomes this sick.
They give you contrast media to look at your heart that can damage your kidneys.
Because of the extent of his infarct, he had multi-system failure. So not only was his heart involved, but his kidneys and his liver. He ended up with an infection, so he had a lot of hurdles to overcome.
There are a lot of familiar faces, actually, just names that we've heard a lot, just from stories he tells when he gets home, and then we started meeting these people in the hospital, and they were involved with his care.
Robert Wood Johnson University Hospital is a large hospital with more than 4,000 employees at the hospital and several thousand at our medical school. But we live and act like a family, and it is statistically rare for family members to get critically ill. So anytime an employee is critically injured or a doctor on our staff is critically injured, we do everything we can to help them as a patient and help their family.
Dr. Anderson is the surgeon who performed the transplant, and there's periods there that I was very, very sick. And I know he stood by my bedside Christmas Day, really managing my care moment to moment.
Every transplant you face the potential of the transplanted organ not working.
I think a lot about the donor family because they affected my life so much. Obviously, they saved my dad's life. Their mom always liked helping people, and my dad likes helping people too. And so I think that was a good connection.
He probably would not have been ready to be transplanted any sooner than he was. The timing was amazing.
The heart I received was received on an emergency basis. The day that I got that transplant, Dr. Anderson was taking me to the operating room to change the mechanical heart because it had some clots in it.
We rely heavily on multiple disciplines, and we need to have an interdisciplinary team available to us.
He had consultants from every field following up with his care. For a period of time, he was on dialysis. He required multiple antibiotics for infection. He required assistance of a pulmonologist because he was ventilator dependent for a period of time.
I think everybody came together. People were very vigilant. Things were done in a very organized and rapid manner.
It was a great relief to know that the support systems were there available for Dr. Laskow. There is the irony that his profession is he does exactly the same thing for other patients, and now he was himself in need of those services.
When I saw him 6 months after his surgery, first thing out of his mouth was, "How are you doing in these meds? Do they make you sick? You put doctors on a high level when they've really taken such good care of you." Now he's talking to you about your same problems.
The process that you go through makes you more sympathetic. I understand the nursing care, the importance of that more than ever before. As a doctor, you tell the nurse to do something, and you think that's all they're really doing. But they're interacting with the patient on a daily basis, moment to moment.
That was a gift from Dr. Laskow and his family, with a card that said it was not only to commemorate his transplant, but also the heartfelt care that he received while he was here. So it's very special to me.
We're all very proud of this, and it's something that will carry for a long, long time.
Doctors wouldn't just stop by and ask. Some of them would sit with us for half an hour, hour at a time. They brought us gifts, and people came by frequently and repeatedly just to ask how he was and sit with us. So I think it was more than just they cared for him as a patient, but they also cared for him as a person.
It did require everybody in the hospital, from infectious disease, who did a great job. Talking about physicians, to Hale was the infectious disease team here, Dr. Nahhouse and his team, to the nephrology group, to the cardiology group, to the surgeons. So there's an ability within the hospital to draw on multiple resources. The technology of putting in a mechanical heart, it's all here. I think they brought it together in my case, but we have the capability of bringing it together in everybody's case.
I've decided to become a doctor. I'm on the pre-med track, and he always thinks that this is because he got sick, and if he hadn't gotten sick, I never would have become a doctor. And just being around the hospital, he thinks that made me want to pursue medicine. Even though I have to say it was about 20 months ago, it seems like a lifetime ago now. I'm happy he's alive and that I can spend every minute I can with him.
That's my baby daughter. Isn't she adorable? So as you can see, it takes a huge team to make this happen. It does affect your family dramatically. And the roles that you played as the strong strength in the family being there does get altered. You'll see later on that my baby is finishing up her 4th year of medical school. So I did want to talk about the models of taking care of people. And there's really probably 4 models and some variations, but you have the old open ICU model, intensivist co-management ICU model, a closed unit, and a mixed unit. Well, the closed ICU model, clearly there's some numbers out there that shows it's worthwhile, it's doing a good job. But I want to take a step back and say maybe there's some issues with it. Clearly, the decrease in unadjusted hospital mortality and ICU mortality. The relative risk for ICU mortality ranges from 29 to 58%, and it reduced hospital mortality. But the concerns is that these are observational studies, retrospective with historical controls. And the thing that makes the studies a little bit worrisome, and you have to take the results with a grain of salt, is that now we have a gatekeeper. And people throughout the country have different philosophies at who belongs in the unit. Somebody might say somebody with dead bowel doesn't belong here. It's not a fixable situation. The family doesn't want support. Let's not bring that patient in here. And somebody else would bring them in. And there's a whole range. That's a drastic example. But there's a gatekeeper, and that person's philosophy influences the outcomes. So concerns, and I think now that we're somewhat of a closed, maybe a little bit of a mixed unit, people do take some input. The loss of continuity of care, when I talk to the residents, they tell me on a Monday, very little gets done because the new attending is learning the service and there's a transfer of information going on, and it takes a bit to have that happen. And then clearly that in a very complicated patient, that not every individual and there is no individual that has comprehensive medical knowledge. And you can see that in some intensive care units, there's a decrease in subspecialty consultants. And so that's an issue that you have to worry about depending on who's running the unit and how open they are to input and agreeing with the input when they have that. And finally, I want to talk about the training of the residents. 2 years ago, Dr. Gracias, who was in charge of critical care services at our institution, came to me and asked if the fellows could rotate on my service for a month or so, and we said, sure. It would give them exposure to quickly doing a retroperitoneal exposure. I don't think that anything could be more helpful for a senior surgeon than doing a procurement where we're taking out the liver, the kidney, the pancreas. You have exposures that you probably would never otherwise see. And there's been a vast experience in the short time seeing a resident that came in and embraced learning about the immunosuppressive drugs, going there, doing procurements, and reaching out and making it a worthwhile experience to another individual who was questioning why they were there and would leave to take care of an event that's going on in the emergency room. And so you get out of these rotations what you put in, and I suspect that would go on for the whole critical care experience for these individuals. I suspect one's going to be a superior critical care attending, and the other maybe not as good. So the training of these residents is an important issue, especially as this group starts expanding, and I think it's an accepted model throughout the country now, and filling the need for all those individuals is really a huge task for this group. Well, one of the things that I have to say as a patient, as a physician, I didn't realize how much anxiety there is as a patient, especially receiving a heart. I have to say the first day I got transferred to the floor, I went over some numbers. I had lost my left main. I had acute renal failure. I had a HIT. I had sepsis. I had pulmonary failure. My liver numbers weren't recovering yet. And so I got my survival rates down to less than a fraction of 1%, and I started having chest pain. So there's clearly some anxiety, and they put me back in the unit for a day just to, calm me down, I guess. But I did notice it was kind of comical. At one point, my white count was about 400. And again, there was a question of CME pneumonitis. They took me from this very carefully controlled room, and they brought me down to the CAT scanner in a hallway where I sat for a half hour. So that quite didn't make sense to me, that I'm in a room that's really well protected, and then you end up sitting in a hallway waiting for 30 minutes. And so the monitoring during that period of time is also, you have to wondering, these are, as everybody knows, dangerous periods when you're moving people around the hospital. Returning to work, I think there's really an interesting thing in the United States, that clearly there are more issues with sick people returning to work who have recovered than our European counterparts. And yes, the physical barriers that you're recovering, you're gaining your strength. One of the issues too is, who's judging you that you can come back? Have you lost any of your mental faculties? At one time, my blood pressure was in the 50s for quite a bit of time. Did that slow me down? Did I have the same dexterity in my hands to be able to do 1.5, 2 millimeter anastomoses? So who's to judge that? Logistics of getting yourself back and integrated into the system in a stepwise fashion. It's not really well organized throughout the United States. There's biases. As a patient, I was really amazed when I was fully awake and trying to understand what happened to me. It was kind of comical to me that, 3 months ago before that, if there's a problem with immunosuppression in the hospital, often I'd be the consultant as a physician who did all the initial studies on Prograft and submitted it to the FDA. But now as a patient, nobody really had any interest in what I had to say about the immunosuppression. So there's clearly a bias against a patient, and even when I came back, I think people were a little leery. And then, the psychological aspect of how you feel about yourself is never really addressed through the medical community. So this is what I was talking about. In the U.S., less than 30% of heart transplants return to work. That's just the flip of our European counterparts. 70% of Europeans return to work. And you have to wonder why there's such a big difference. And yeah, the level of physical activity. But I think one of the big things here is at the age of transplant, we get transplanted about the same age. But in the United States, if you go out in disability, say you don't go out in disability, and then you find you're not capable, it's hard to go back and claim full disability. So if you're looking ahead and you're 56, 57, most of those people in the United States, when you look at that group, the majority of them are going out on permanent disability because they're afraid if they try and fail, they can't reclaim full disability. It's much harder to backtrack. So the age of transplant is important. Your education, what type of work you're doing, clearly is important. How long you're disabled before you feel you can go back to work. The type of health insurance you have clearly plays a role. And the patient's own perceived ability to work. Well, as I mentioned, there's a fear of losing disability that in some areas of technology, being out for 6 months, maybe a year, you're no longer relevant. Your technical skills have been passed already. And the community's perception of your abilities play a big role. One of the issues, again, that's hard to talk to people about is life planning. And this next slide, I think it's the next slide, well, you'll see coming up that the heart transplant, on average, 50% are dead in 10 years. So you have to really keep that in mind when you're making your life plans. And then as a recipient, you have to understand your physiology. You're never going to be the same person you were before physiologically. The heart just doesn't work that way. There's no innovation to it. You're stuck with a heart rate that ranges around 100, maybe 90 to 100. And then when it finally does respond, it's about 15 minutes after the fact. So you might run up a couple of staircases, try to work out, and then 10 minutes after you're done, your heart starts beating appropriately, and like, great, now. And then when you want it to stop, it takes a while to stop. You're already sitting down, and your heart rate has moved up, but you no longer need that extra heart rate. So there's a chronotropic incompetence, there's an increased heart rate that's hard to move off its baseline, a delayed normalization of heart rate after exercise, and there's constant diastolic dysfunction. So this is the slide I was talking about. I fit into this group at the time of transplant, being 50. That's this line here. And so when you look at 10 years out, it's around 55%. And so that's some of the things that you have to think about when you make those life plans I was talking about. In 10 years from your transplant, where do you want to be? What do you want to be doing with your life? And again, these are some of the things that are probably beyond the critical care community, but needs to be addressed with the individual somewhere along the line. So things to think about, at least what I did think about, is the donor age. 50 for the donor is somewhat older. Having a female donor is somewhat problematic. Being intubated at the time of transplant also predicts poorer long-term outcome. Acute renal failure at the time of transplant predicts poorer long-term outcome. And then you're happy to reach that 10-year anniversary. I'm pleased to say I'm at 9 years, looking forward to that 10th. I always think I'm a little bit above average. And then the history of acute rejection is huge, that every time you've had an episode of acute rejection, it really impacts long-term outcomes. And so you really want to be as compliant as you can with this group, with your medication. And I'm amazed, I'm involved with the heart transplant community, looking over our heart transplant center, and you'd think that one group of people that would be unbelievably compliant with their meds is heart transplant recipients. But we have the same problems with compliance as every other group of doctors with their patients, which is just mind-boggling to me. Well, as a patient-physician, I was impressed by the multidisciplinary teams, the outcome, nursing, the support team. It really, as a physician looking at that, I knew it was there, but as a patient, really appreciate that it is the team, the critical care team, that gets you through all that. Concerned about the family finances, again, never addressed. Transition points I mentioned, keeping the family informed. I could see my particular family was informed, but I could see if we weren't in the medical community, that's an issue. And I think that becomes even more problematic in a closed unit because that relationship is not developed. And so I think that the nurses play an important role in communicating to the family because the doctors are changing, but the nurses are not. And again, one thing as you leave the unit's thrilled that you survived and you're leaving, but they're not thinking long term. And that's, again, when you go from a unit where those doctors are finished with you when you leave to the old-fashioned one where the doctor follows you through, I think that was one of the advantages of the older system. So one of the things that does concern me when I look in the newspaper, yes, overall health costs are going down, but we're shifting more and more costs to the patients. And I'm amazed when I see some physicians in the emergency room departments and physicians within the hospital, whether it's radiology or some critical care teams, that are outside the hospital's insurances. Patients are getting these huge bills, even though they're directed there by the insurance companies. They're shocked to see a bill because certain physicians were outside of that, and they're unaware of it. So I think we have to be very careful as a community to make sure that we're not overwhelming the patients with this cost. Now, again, in the papers recently, there's been an effort to make sure that the patients aren't overwhelmed with cost, but it's still a problem. So there's out-of-service charges for the physicians, for labs, tests, and so on. Well, so as a physician and patient, what did I take away with this from the different models and from the care? I really think that it all depends on your institution and the people working there. That I think clearly the intensivist needs to be there, whether it's mixed or closed or there's a larger role for consultants. It really depends on you, the individual, and what's best for your institution. It all works well if you have the right people in place. So the long road travel, as you can see, from a patient to someone who's operating. I get to do cool cases. Here's a nice kidney getting ready to put in. This was a horseshoe polycystic kidney, about 1 in 5 million. It was a great case. Still love doing these things. This is my daughter a few years ago in her white coat ceremony. Here's my oldest getting married, dancing with her. And here's my middle one getting married, walking down the aisle with her. They stressed me a little bit in that they got married with less than a year apart. And as you can imagine, that's always a little challenging. And I guess they felt my heart was up to it. So I started off saying, thank you for having me here. But I have to end by saying I wouldn't be here without this community, and I thank you for letting me stand here before you as a healthy adult. Thank you.